We all have heard Dr. Vineet, I think on many occasions when he was in Apollo Spectra also organized many CMEs, and otherwise also we have heard on 2-3 occasions. Dr. Vineet Malhotra is an eminent urologist. He has post MCH 17 years experience, and he has special interest in andrology. I think we have heard him on topics of andrology 2-3 times. So today we will discuss 2 topics. One is on andrology, erectile dysfunction, what is new, something new is coming out, and prostatic carcinoma. Prostatic carcinoma, what is new? But we all know that prostatic carcinoma symptoms may not be very different from benign prostatic hypertension. So we must hear from the experts what is new in erectile dysfunction and prostatic carcinoma. Dr. Vineet, please. You can start yours. Please welcome Dr. Vineet.
Thank you for your kind words, Dr. Poddar sir. It's always a pleasure to be here because as Dr. Thank you again, Dr. Poddar sir, for the kind introduction. It's always a pleasure to be here with the Physician Forum of India because again, our association goes. Thank you. Thank you. So, we've had a very long association, and this is the first CME that we are hosting for VNA Hospital, and we thought that it has to be most appropriately held with Physician Forum of India. So we actually have got our official registration today, and the first CME that we are holding is with all of you, and it's a pleasure for us, it's a privilege for us. So thank you for being here today. Now, today we intend to do 2 topics. I'm going to run through them quickly, but one of them is about a new drug which is available in the market. And I always like to talk about this because you will come across prescriptions and wonder what is different about this drug. You may wonder, you may already know about it, but let's talk a little bit about it so that we understand how this is different from other Pd5 inhibitors which are already in the market. So, Avanafil. Is this? Yeah. Now, we know how ED is defined. Some of the things may be repetitive because we've done andrology topics a lot of times, but a point that I always make is that patients will say, I have an erection. In fact, very interestingly, when I was coming into this meeting today, one of my urologist friends called up and said, there's a couple, the husband has been accused of impotence. They've just been married about 8 months. Husband has been accused of impotence. The wife's family is saying that he doesn't get erections. The man has...
please, I request everybody to maintain silence. Please, simpler people also. And the backbenchers also.
backbencher तो फिर होते ही इसीलिए
Complete mental silence.
So-
Just give respect to the speaker.
So, the man actually showed photographs to his doctor, the urologist, that he gets an erection, and it's not about getting an erection. Now, I was actually brought into the picture because the legal angle had come in, and they wanted legal evidence, both of them, the husband side and the wife side, that he's potent. It's a very difficult question. Unfortunately, the legal system is blind here also. So what they look at is the physiologic ability to have an erectile response, which has nothing to do with erectile function, by the way. Now, what is the definition of normal erectile function? That erection which is gotten and sustained for satisfactory penetrative intercourse. Now, that entire thing is the definition of normal erectile function. So it's not just about being able to get an erection. You have to get an erection, you have to maintain an erection, there has to be satisfactory penetrative sexual intercourse. And that entire thing has got to be. Now, how do you test for that? It's very difficult. So in a clinic setting, you cannot test for it. So what we do is we do tests which are representative of this, which means we check for potency, which is physiological response. We may give a drug, we may do a color Doppler, penile color Doppler, or we may do a NPT, we call it a Rigi scan, which means we make the patient, so we know that in the REM phase of sleep, you're supposed to have these long periods of tumescence. And so if you don't get a tumescent period of about 10 to 11 minutes, it's almost 85% predictive of the fact that we may be suffering from ED. And there are usually such 2 or 3 such tumescent episodes. That's how we try to prove that erection happens. It's nothing to do with potency, unfortunately. So any treatment that we give for erectile function must measure the response. So we kind of tell our patients, and I tell my patients, there's no gray zone here. It's an all or none phenomenon. You've either had satisfactory sex or you've not had it. If you've not had that, this has not worked. This therapy has not worked. If you have had that, then this therapy has worked. So there's no gray zone in between, because a lot of men will say, I had some erection, or I had good erection, but I wasn't able to perform, or I wasn't able to penetrate. But I had 50% response. There is no 50% response here. There is grading of erection hardness scale. You have 1, 2, 3, 4. But the response that we are looking at is a successful act and nothing less than that. So we know any erectile dysfunction has a huge impact on quality of life. You see men coming into the clinic, and you can actually make out a couple that's walked in. A wife is walking in like a tiger, and the man is kind of slipping down on the floor. And you can kind of make out that this is erectile dysfunction that you're dealing with. It's very common. We use the acronym 40 by 40, which means 40% of men by 40 years of age will have some form of erectile dysfunction. It's a very well quoted study. It's called the Male Massachusetts Aging Study, and that said 52% of men about 60 years of age will have some form of erectile dysfunction. So it's very, very prevalent. And again, we know now with the metabolic factors that come in India, being the diabetic capital and all of that, that the incidence in India has also risen tremendously. So the age-wise prevalence, very common. There's a word of caution here. Never underestimate anyone. So I learned that in practice too. I had this in my training years, this Gujarati gentleman would come from a village, and we were to do prostate surgery. And I didn't ask him about his sexual history. And he reprimanded me. He was about 82 years old. And he reprimanded me for it. He said, I have very healthy sexual activity, practically thrice a week. Is this going to affect my sexual performance? So you get taken aback. So never assume. It's always good to know the history before you. This is very important for us because when we do prostate surgery, these men end up with complete retrograde ejaculation, and some of them are very unhappy if you have not counseled them about it before. So, a lot of patients come in with comorbidities. Now, we're talking about this because this new drug has something different to offer, and I'll come to that. So, a lot of diabetics, a lot of them with coronary artery disease, and we know, this concept about endothelial dysfunction and how that is responsible either for arteriogenic or venogenic erectile dysfunction, which means either the inflow is poor or the inflow comes in, but the venous mechanism which is supposed to get occluded so that the blood stays inside for the erection is not effective, and you have blood which leaks out, and so you have erectile dysfunction. Now, treatment for erectile dysfunction actually changed dramatically in the late 90s. Before that, a lot of surgery was done for erectile dysfunction because you did not have effective drugs. So, very short, interesting story. The treatment for erectile dysfunction changed before that also. So, there was this AUA meeting which happened, I think, in Vegas, and there was this British neuropsychologist who actually injected himself with phenoxybenzoline before the meeting and then showed his full erection. So this was a demonstration of intracavernosal injection of a erectile response. That actually brought in intrapenile injections. Intrapenile injections never became too popular because it's uncomfortable. Tell a patient that you have to inject yourself every time before the act, they're not too happy about it. So penile implant surgery actually prior to Viagra was a very, very common surgery. It was done because you had nothing in between. You gave some medication, herbal medication or whatever, and if that didn't work, you had to offer penile implant surgery. You had vascularization surgeries and all of that, but they had high complication rates, high failure rates, they never worked. So penile implants were done far more commonly then. And then came Viagra, which changed everything else. And that brought in the first line therapy in the late 90s. That was followed very quickly by tadalafil and vardenafil. Vardenafil somehow never made it to our country as a common drug, but that's where it remained for a significant period of time. With that, there was intracavernosal injection therapy. We use a lot of that in a lot of patients, and that's very effective. The intra-urethral therapy, which is called Muse, and we say Muse is to amuse, which means it actually doesn't work. There are huge concentrations to be put on this in the urethra for it to absorb through the thick tunica albuginea, which has two layers, and it has to go through that into the cavernosa, so it doesn't actually reach there, it doesn't work. But anyways, Muse has become a popular marketing gimmick. And then you had the working penile implants, either the malleable or the inflatable devices. And for a long time, these were the devices. So the algorithm which the EAU actually laid out was you did a medical and sexual history, lifestyle factors always, smoking, sedentary lifestyle, obesity, all of which would promote erectile dysfunction. If you had a treatable or a curable cause, you rarely have curable causes of ED, but you have reversible causes of ED. And then you would use intracavernosal injections for a short time. Vacuum devices we've never favored for treatment of ED, but oral Pd5 inhibitors changed all of that, and that allowed treatment to be effective. But if you had treatment which was ineffective for any reason, if you had treatment which was ineffective for any reason, you would end up with penile prosthesis. There's this low intensity shock wave therapy that's spoken about, which is good as a temporary measure for mild to moderate vasculogenic erectile dysfunction. And as we look at PD5 inhibitors, as I mentioned, late 90s, sildenafil followed by vardenafil, never made it to our country. Tadalafil became very popular, and both of those have their independent indications. And then you got avanafil. We actually got avanafil much later. So we were exposed to the use of avanafil back in 2014 at an EAU meeting in Munich. But following that, we never got it in our country. I'm going to skip some of the regular mechanisms because the purpose of this talk is not to talk about other drugs but about avanafil. So again, it's also a PD5 inhibitor like the other agents. It's called a second generation PD5 inhibitor. The difference is actually here. So one, its onset of action is very early. So we mentioned half an hour here, but we see action as early as 15 minutes. And it makes a difference for an on-demand drug to be used this way, because you have a lot of men that don't want to plan a sexual act. They want to take drug and they want to be ready for action. So this is as close to an injection that you will get ready for action. And an injection you get ready for action in 5 minutes. With this tablet you get ready for action in 15 to 20 minutes. That's as close as you can get to it. It's less affected by food. So again, that's not a point which makes a difference. It has a duration of action which lasts for 6 hours. So you actually are much safer with other drugs if you're using them, alpha blockers or other agents. Even with nitrates, if the duration of gap is sufficient, 24 hours, it's safe to use avanafil. And it has a very low side effect profile. So avanafil amongst all the PD5 inhibitors comes in with the lowest side effect profile because it's highly selective PD5 enzyme subtype. Faster onset, lowest incidence of side effects. It has a much shorter duration of action, and it actually can be taken just 15 minutes before the act. So that's what makes it a very, very useful drug for a select group of men. So you look at younger men that are looking at faster onset of action, on demand, they want to have, they've got unplanned intercourse and they want to have a medication at that time. So again, efficacy and safety profiles have been well studied, well documented, and they found that there's improvement. So efficacy point of view wise, there's improvement in both SET2, SET3 scores and the IIEF domains, and extremely low incidence. So this is where we find that the vaginal penetration endpoints are much better. The SET2 scores are much better compared to placebo, and 200 milligrams giving you a better response than the 100 milligrams. So it comes in two preparations, 100 and 200 milligrams. It's also available internationally in three preparations, 50, 100 and 200 milligrams. 200 milligrams being the maximal dose. Though these are the side effects that are common, but it's extremely uncommon to have severe side effects with avanafil. So very safe and well tolerated drug. Now remember, a word of caution here, because when we look at new drugs, we start thinking this is the magic pill. No, it's not. When you say low adverse effects, it also means lower efficacy as compared to a sildenafil or a tadalafil. So on a equal dosing response, avanafil has a slightly lower efficacy to the sildenafil and tadalafil agents, but then it's far more useful because the adverse effect profile, fallout rate is much lower, dropout rate is much lower. Studied in patients with diabetes, mellitus, again found to be safe, effective in men with diabetes, with effect lasting up to 6 hours after the dose. Again, plenty of studies, all of them showing that it is safe and efficacious. And they've actually compared, in all these studies, they've compared placebo 100 milligrams and 200 milligrams to find the efficacy as early as 10 to 12 minutes after the dosing of Avanafil. So we actually do something that's called the Avanafil office test. We used to do a sildenafil office test, which means we used to give sildenafil to the patient and see the response after an hour. Now we give Avanafil in the clinic and we stimulate the patient or ask the patient to stimulate himself just 15 minutes after taking the tablet, and we see the response. We call that the Avanafil office test to differentiate between psychogenic and organic erectile dysfunction. So you've had some studies which have compared requirement of dose escalation and found that there's a lower requirement of dose escalation in Avanafil versus sildenafil. Though in practice you'll see efficacy-wise sildenafil will score slightly higher than Avanafil. And there's also an Indian study which has shown a fairly good efficacy and very good tolerability in all patients with Avanafil. So it's available in 50, 100 and 200 milligrams dose. You can start with, so we call it the top-up dosage when you start with a base dose of 100 milligrams and go up, step up or step down. My personal preference is actually to do the step down therapy, which means because it's got a low side effect profile, I like to start with the 200 milligrams, and then if it's showing some adverse effects or it's very efficacious with the first dose, I may do a step down. The maximum recommended dosage is once a day, 15 minutes before sexual activity, and can be taken with or without food. We know that with sildenafil we want to avoid it with a very heavy meal. Again, it's been confirmed to be efficacious in men with various comorbid conditions. There are studies which have shown that 200 milligram dose may be more useful. We in fact use it more commonly than the 100 milligram dose. So, very short summary, remember the definition of PD, remember that it may be associated with comorbid conditions, Pd5 inhibitors recommended as first line therapy, and we have now in our country a newer, faster acting, quicker onset of action and lower side effect profile Pd5 inhibitor available. Thank you for your kind attention.
You can start the second talk. So, Dr. Vineet, 9:45, so I think
We'll finish this very quickly.
20 minutes.
No, 5 minutes.
No.
Let's have some question answers.
Yeah, 15-20 minutes. Yeah.
I'll finish in 50 minutes. I'll finish both the talks and then do the question?
Yes, questions will be at the end of both talks.
Please finish this in about 5 minutes.
5 minutes?
No, 15 minutes.
minus 5 minutes.
उससे क्या हुआ?
So
थोड़ा beer.
So I'll just talk quickly about this, which means now we know this is true about all cancer, which means the loss of controlled growth or the uncontrolled growth is what causes this cancer. Fourth most common cancer worldwide, second most common cancer for men worldwide, and we've been finding that in India too the trends have been rising. The risk factors associated with it include aging, diabetes, obesity, smoking, very importantly family history. So we always ask men that have had a strong family history of prostate cancer to start testing their PSA as early as 40 years of age, because you can pick up the prostatic cancer early. Now, all of the mechanisms which may be involved in an increased ROS production, inflammation, prostatic intraepithelial neoplasia, all of these may have an effect to allow this apoptosis or uncontrolled growth to happen, loss of control to happen in the formation of cancer cells. Now, what supports the... I'll be quick here because I just want to talk about certain things here. And we know that there are two phases of how prostate cancer grows. Again, important because in your practice you'll find both. You'll find one which is hormone dependent, which through this androgen receptor mechanism is going to be controlled as soon as you put in androgen deprivation therapy. And you'll find that which becomes castrate resistant, and we call it CRPC, prostate cancer, because that's something that's grown up, which means the intracellular mechanisms which were controlled at that time by this step here, and if you were able to actually control this step here and cause androgen deprivation, you actually were able to control the growth of that cancer. They've now developed other mechanisms for growth, and that becomes the hormone refractory or the castrate resistant prostate cancer. And it's important to recognize this because these are the men that will now require other forms of therapy. Again, important here because certain management principles have changed. We have localized, so we actually have incidentally diagnosed cancer, which is T1. Then you have localized prostate cancer, which is the T2 stage. You have that which goes into just the seminal vesicles or the surrounding tissue, which is T3. And then you have that which goes into bladder, pelvic side walls, and rectum and other areas. And you have T4 disease and then metastatic disease. So, unfortunately, if you look at European studies, the metastatic disease incidence was much lower than what we found in our patients. So we unfortunately are still getting a lot of metastatic disease at presentation, and that precludes the performance of curative treatment. Now when I say curative treatment, we talk about surgery or we talk about radiotherapy. So either laparoscopic or robotic radical prostatectomy versus brachytherapy or external beam radiotherapy, which may be used as treatment. Again, we're not going to questions here. So we've spoken about this, but the usual lead time between a hormone dependent or a hormone responsive disease to a hormone refractory disease is usually about between 1 to 3 years. And as someone mentioned, the symptoms are very similar to how benign disease presents, which means maybe asymptomatic, which is why we find a lot of metastatic disease. You may have local symptoms, you may have symptoms due to spread such as, so bone pain is a common symptom, weight loss, malaise, anemia, sometimes pathological fractures, spinal instability. Particularly bone pain is something to keep in mind for metastatic disease. Digital rectal examination, PSA, transrectal ultrasound and biopsy. A lot of men are very fearful of this biopsy. A properly prepared patient does not have a risk of infection or complications following a biopsy, which is done with transrectal ultrasound guidance. Also remember, it's been shown that if you're using antibiotic indiscriminately before a biopsy, you actually increase the incidence of infection following a biopsy rather than reduce it. I've mentioned this here because there are a lot of unnecessary tests that are done for evaluation and assessment of local disease or metastatic disease for cancer prostate. Either of these two are fine, but the multi-parametric MRI prostate, if you're not doing a transrectal examination or a biopsy, then MP-MRI is indicated. Otherwise, a PSMA PET for evaluation of metastatic disease is most accurate before surgical therapy. So if you are contemplating surgical therapy, that's the test that you want to have before that. We in fact now don't recommend bone scan separately, because if you've done a PSMA PET, then it makes no sense to then do a bone scan separately. So won't get into this. So what is the treatment? It will depend on the course and outcome of cancer in the patient and the patient's life expectancy, which is why we say, you get an 85-year-old gentleman don't do a PSA in him. It makes no sense. If he's being diagnosed at that age, he will have a probable expectancy for another 12 to 15 years, and you're not going to operate him at 85 or 90 or 95. So no point in doing a PSA then. We put him on watchful waiting most of the times. But if you are looking at someone who's fit, say a fit 75, you would then look at investigating him completely with the intent of actually performing a radical prostatectomy. We've spoken about the TNM staging. Gleason score is another thing that we talk about. Gleason grade and Gleason sum. So this talks about the differentiation pattern, which means from well differentiated to very poorly differentiated is how Gleason 1, 2, 3, 4, and the minimum Gleason score or the sum that you start at is 4, which is also very unusual to find. We usually start at 6, which means we say 6 and below is well differentiated, 7 is moderately differentiated, and 8 to 10 is poorly differentiated, and that's how the treatment also varies. Though these days we've started to operate men even with, we call it low metastatic potential disease, which means these are men that have very few areas of metastasis, and you may still go ahead and do radical surgery in these patients and follow it up with adjuvant therapy. So you're looking at patients that have been categorized on Gleason score, on TNM staging, and on PSA. So PSA less than 10, Gleason less than 7, and a TNM which is up to T1 to A is low risk disease. There are several options for it. We call watchful waiting also one of the options. Very popular in Europe. We don't do it here at all because you're required to actually follow up the patient with serial tests every 3 months. Intermediate disease, which is PSA between 10 to 20, Gleason 7, and T2B, and then high risk disease. Treatment options vary for locally advanced and metastatic disease. We've done this, so I'm going to talk about treatment that we give. Low risk disease, you may actually observe this patient. A lot of these patients will actually opt for surgery, and you'll end up doing a very good radical prostatectomy, which is curative in these patients. We do a laparoscopic radical prostatectomy with very good results. Intermediate disease also does very well with radical prostatectomy. Just make sure that lymph nodes are removed. We've actually now started to extend our indications and do it for high-risk localized prostate cancer also, and also locally advanced disease. It's only the metastatic disease where you start looking at androgen deprivation therapy, and there are a variety of therapies which are the palliative forms of treatment. Most of these first line, second line treatments are hormonal therapies, and once they become hormone resistant, then you're looking at chemotherapy as also an option. Now, what I wanted to also talk about is laparoscopic radical prostatectomy, because you hear a lot about robotic radical prostatectomy. Remember that both of these put the control into different arms, which means you have a robot controlling a surgeon on a console, and the robotic arms controlling the robotic prostatectomy, and the laparoscopic prostatectomy being performed by the surgeon himself. If we are able to give the outcomes which are as good or better, then both procedures are essentially similar in their outcomes. We found that in our patients with a prostate that is localized or locally advanced, where we've done laparoscopic radical prostatectomy, we remove the catheter on the 5th day. We very rarely use blood transfusions in such patients. They're catheter free, they're dry in 2 to 3 weeks, which means no incontinence after 3 weeks. And in about 1/4 of them, you'll hear a lot of onco surgeons or even uro-oncologists say that potency is maintained. Potency is usually very rarely maintained after radical prostatectomy, and they'll require some form of support. So, genetic factors like age, race, and family history can kickstart prostate cancer, and androgen will drive its growth. Androgen deprivation therapy can ablate this growth pattern in those that remain hormone responsive in the first phase, and then that metastatic disease will come, which was initially responsive to androgen deprivation therapy, but eventually gets activated and becomes refractory. And this refractory hormone resistant prostate cancer then requires additional therapy. I hope I've been short enough.
Yeah, thank you, Dr. Vineet. So, you can come here, Dr. Vineet. So, regarding your first lecture, you said intracameral injection never became popular, maybe in India or maybe everywhere. So, one reason may be the fear of priapism also. And what is the incidence of priapism after intracameral injection?
Excellent question, sir. So, priapism, so we define priapism. Any erection which persists for more than 6 hours is defined as priapism or persistent erection beyond 6 hours. And it leads to ischemia and ischemic damage to the cavernosal musculature, which can lead to permanent erectile dysfunction. And that's been a fear in the mind of not only urologists, but a lot of radiologists also who are doing penile Dopplers. Because the idea or the habit was to inject with papaverine only. When you inject with papaverine only, you have a undesired response with a low dose, which means you get no erection at all. And so, papaverine comes as this 2 ml ampule, and you have 30 milligrams per ml of papaverine in it, and you would actually require about 120 milligrams of papaverine to get a full-blown erection in a lot of men with PD. And that had a very small window of error, margin of error, because you could have no erection or you can have a priapismic episode. To counter this, if you were to use biomix, which means you add a synergistic acting agent called chlorpromazine, you are able to reduce the dose considerably. Which means here we end up using as little as 5 to 7 milligrams of papaverine only and 0.6 to 5 milligrams of chlorpromazine only. And you have an episode which can be controlled. Again, we always do we call it an IC VAD or an intracavernosal injection of radioactive drug test in the clinic, see the response duration. There are downers available, which means there are agents available which can put down an erection, such as adrenaline or phenylephrine. So if you have an erection which lasts longer, you can just put it down with an injection, 50 mics of adrenaline or phenylephrine. And so this controlled erection, if you know how to manage, you can prevent priapism. But it's been one of the very important reasons why injections are not being taken.
If there is priapism, the patient should go immediately to his doctor, because otherwise this will go into fibrosis.
It is a urologic emergency and the patient must reach the hospital immediately.
So, and regarding your second talk, I think if we have to diagnose prostatic carcinoma in early stage, we must think in all the cases of benign hyperplasia also it can be malignancy. So a good per-rectal examination, as you said, it is very essential. You have many times without doing a per-rectal examination, just we look at PSA, and if PSA is normal, we start this drugs for benign hyperplasia. So a good per-rectal examination is essential, and if needed, biopsy, and it has to be multifocal biopsy.
Absolutely.
So thank you. I think we now give floor to the our speaker, Dr. Chauhan. Just deviations, Dr. Chauhan will ask the question first, then Dr. Tulsi.
No problem. Dr. Tulsi is my brother, so no problem. He will afford me that. I will ask some questions, sir, which will interest everyone, and then Dr. Tulsi will ask you some very scientific questions. Be prepared for that. Dr. Abhishek, what is the cost of TKR and total hip replacement in your setup now? It's your hospital. You are not operating under any duress, and you are your own master. So what is the package now for TKR and THR in your setup?
It depends, like.
Take the mic, sir. Take the mic. Speaker mic. Speaker mic.
Let me tell you, sir. Are we talking about the cost of TKR, THR in general, or are we talking about
In your setup, not in general, we know in general.
So honestly, it depends on the one thing. The only one limiting factor is that is comorbidities. Like whether the patient has any serious diabetes issues or heart issues or not. And then we need to involve our colleagues. And obviously we can cut on our fees, but we would never cut on our colleagues' fees and the medications required.
Give me an average package, sir, please.
So average package, suppose I'll just give an example, sir. A patient who is, in fact, we are about to launch, like in 5-10 days, we are going to see this campaign in which we are going to do unilateral total knee replacement at a package of approximately 1.25 lakhs, 1.25 to 1.3 lakhs.
Including the process?
Including everything.
1.25 lakhs?
Yes, including everything, provided the patient does not have any serious comorbidities, like an uncontrolled diabetes or some heart ailment.
So you need to say 2.5 lakhs, both the knees?
For both the knees, absolutely. Right.
Great.
So 15th of August we are planning to launch it, and you will be the first ones to know about it.
Great, that's very good. That is very reasonable also.
Thanks.
Please. Dr. Vineet, wonderful presentation. Reminds me of the first presentation I was privileged to hear in Sukhmani about 20 years ago. Maybe more, maybe actually more. I wanted to know when a patient lands up with you and has serious comorbidities, then the treatment that you planned out is still the same, or you have an alternative way? Uncontrolled diabetes 500. Very common situation at times. Patient comes to you, no, I'm not worried about diabetes. My issue is only erectile dysfunction. Can you sort it out, doctor?
Excellent doubt resolved. I would want his diabetes to be controlled for my treatment, no doubt about that. But yes, if he is not taking, there are absolute contraindications for use of Pd5 inhibitors, and the most obvious one is where nitrates are being used. So if he is not using nitrates, if he has not had a recent MI and is fit for other physical activity, we actually calculate that by the meds he can perform. Or if he's not taking drugs which increase the potentiation of these Pd5 inhibitors, then he's a safe candidate as someone who can use a Pd5 inhibitor. So he would go on a Pd5 inhibitor therapy, which is why the first thing that we do in the clinic is give a pill. Sometimes these patients are surprised, they expect a battery of tests, they expect a battery of things to happen. And they've come in and I tell them, have this pill right now. I'm going to see you again in 15 minutes. And that's what I'm going to see. And it makes a huge difference to them.
And the other medications which you mentioned have become popular in India. What about this new medication, Adinafil? Is it available in India? And how is it better over, let us say, sildenafil or tadalafil?
So sir, it is available in India. We have 100 and 200 milligrams preparation of Avanafil available in the country. It is much safer than the other Pd5 inhibitors. So when I talk about Pd5 inhibitors, you know that a lot of Pd5 inhibitors, or both of the Pd5 inhibitors that we use commonly, sildenafil and tadalafil, will have a dropout rate because of adverse reactions, either headache or visual disturbance or severe muscular aches as with tadalafil. And you'll have these group of patients that will then not use Pd5 inhibitors. This has a very low adverse effect profile. So that's one group that's going to use this absolutely. Now the second is the one that's going to use on demand. And a lot of young men that come across, they say, I can't plan taking a tablet 1 hour, 2 hours before the act. It's impossible for me to do it. Can you not give me something that even if I have not remembered, I can pop it 10 to 15 minutes before the act and I'll be ready. And this is that drug.
That is Avanafil?
Yes.
Alright. Great, sir. As always, sir, it has been a wonderful presentation. At times, and we have heard presentations from you, people require processes.
Yes, sir.
And you've been a great exponent of that. and I think you've been trained under one of the best persons, I would say, in West India, in Gujarat. Dr. Shah, if I remember him correctly, he's been your teacher on that. Sir, what is the average cost of those prostheses, and is there a maintenance cost also?
So, to the prosthesis, there are three types of prosthesis. The Indian malleable, which is the Shah prosthesis, the American malleable, and the inflatable. The Indian malleable package cost is between 1.25 to 1.5 lakhs. The American malleable is between 2.5 to 3 lakhs. And the inflatables cost between 6 to 9 lakh rupees. This is all inclusive packages that you have for these.
Any maintenance cost?
There is no maintenance cost to prosthesis.
There is no maintenance cost. And how many would you have done by now, if I can ask you?
Many, sir. More, I would say many hundreds, maybe thousands.
Maybe 1,000. All right. Good results?
So that would be very good.
Great, sir. Great questioning by, I would say, great answering by you.
I'm interrupting, just take 1 minute, sorry. What did you mean when you said maintenance cost?
Of the processes. Of the processes. Of the process.
Not of the party. Sir, maybe.
Yeah. About Dr. Tulsi, sir.
So after those wonderful questions from our friend Dr. Chauhan, I was looking forward to some observations and talk on arthroscopy, on arthroplasty, on disectomies, on disc arthroplasty as well from Dr. Abhishek. Maybe we can have it next time.
Sir, of course.
Okay, so to Dr. Vineet. Wonderful talk, sir, as usual. So, ED in 2022, sildenafil, tadalafil remain the most reliable treatment. 80% of the men would respond to it. So, why would you like to switch to vardenafil or to evenafil? Is it because the rapid action of evenafil, just 10 minutes before the fun starts?
Very good. Very good.
And less side effects. The color perception that we have with sildenafil is not there because it doesn't inhibit the PDE5. So, the PDE6 and the PDE1. So, is that a big advantage?
So, again, as usual, your questions are in depth. That's the point that I was trying to make. Don't look at replacing all PD5 inhibitor therapy. Efficacy-wise, it's still sildenafil and tadalafil which hold the fort. But you'll have a lot of dropouts with it. And these dropouts commonly happen because of adverse effects and sometimes non-usage because it doesn't suit them. They don't want to take a drug 2 hours before or 1 hour before. They want a quick action treatment. So for this particular group of patients, evenafil actually is a window of opportunity because that's allowing them to use a PD5 inhibitor. Otherwise, they would have moved to injections. Now remember, a lot of men are they are absolutely scared of the fact that they would have to use an injection to create an erection. So for them, imagine an option. You can't use PD5 inhibitor, what next? So evenafil has given them that choice.
I'll talk about what next, Dr. Vineet. So the DHEA, see, we have seen that this is deficient in 30% of the population in type 1 and type 2 diabetes. Any role of DHEA? Because we know this is a precursor to the sex hormone, the testosterone as well as the estrogen. Just a word on the DHEA.
So what was done was, now when this started, they wanted to look at the impact of hormone on erectile function. And there was huge alabla over this, so they said low testosterone, complete erectile dysfunction and all of that. And they did a study in castrate men and testosterone deficient men, which means those that had Klinefelter syndrome with testosterone less than 200. Most of them were potent. Most of them had very active sexual lives. They were infertile but not impotent.
Right.
That's where they realized that testosterone did not control erectile function to that extent as was believed before, which is why if you look at testosterone replacement therapy for erectile dysfunction, it never became popular. Why did it not become popular? So it did not become popular because any hormone, such as DHEA also, did not become popular because that replacement therapy for raising either intratesticular or intravascular testosterone did not result, it did result in something. It resulted in improved libido, but did not result in improved erectile
So
function.
this is the hormone which causes arousal, not only
Exactly.
in men, also in women.
Female, yes.
Exactly.
Right.
Right.
Okay, so Dr. Vineet, my last question on ED would be on melatonin receptor, melanocortin receptor agonist, see, centrally acting, and it initiates reductions without any stimulation. A trial probably is needed, but this says that this is the drug to be given for people who do not respond to Pd5 inhibitors. Just a word on melanocortin receptor agonists.
So a lot of work is being done on central acting mechanisms for erectile function, and I'll tell you where it's acting from. Now, this is not about the erectile or the erectogenic drugs, but rather the drugs which prevent inhibition of erection.
Right.
So we have two pathways. We have an erectogenic pathway and we have an inhibitory pathway. And now a lot of focus is working on the inhibitory pathways, which means if you remove the inhibitory pathways, you are able to get a sustained response without stimulation. Unfortunately, we are not there yet. This is still experimental data. But there will be a time where we will have answers on this. I tend to use, now you actually used a word of melatonin instead of melanocortin. I actually use a lot of melatonin also.
Yes.
I was going to come to melatonin.
Right.
Now remember, melatonin is something which stabilizes your REM sleep patterns. Your nocturnal tumescence periods are best in the REM phase.
Absolutely.
And it's been shown, so which is my hypothesis, again, this is all things that we do in terms of our effort at trying something, is to make this REM phase as stable as possible and get a better erectogenic response. So we are working at it. We don't have answers there, but yeah, we are working.
So my last few questions on prostate. So robotic radical prostatectomy probably remains the gold standard. And how do you compare it with radiotherapy? See, no large-scale trials are there, but probably we know that if you can do robotic surgery, you would probably spare the vascular nervous bundles, and probably prevent erectile dysfunctions and urinary incontinence to a large extent, as probably would not occur if you do a prostatectomy. Your word on that?
This is something that I always like to speak to the uro-oncologist from. So I had this uro-oncologist from Mumbai who said, I have 97% potency rates in my patients. I said, even normal patients, we don't have 97% potency at that age. So there's a lot of exaggeration in what is spoken about potency after radical prostatectomy, whichever form of radical prostatectomy is done. No, I'm saying whichever form.
Okay.
All of them do not give us greater than 25 to 30% chance of potency, including robotic. So now remember this, and I always say this, the method of surgery is only as good as the surgeon that's doing it. Patrick Walsh doing an open radical prostatectomy gives better outcomes than most robotic surgeons in the world. and it's been shown in his the data that he's presented over the years. So this is a man that's doing open radical prostatectomy, giving us better outcomes than most surgeons with robotic radical prostatectomy. So there's a lot of input into how the radical prostatectomy is performed, who's doing it, and the outcomes. We do a laparoscopic radical prostatectomy. We don't have a robot with us, but we have excellent results in terms of continence, in terms of catheter-free period, which means we have catheter-free period as early as 5 days post prostatectomy. So those are the good results. Potency, I'm still going to say that we do, and again I can say it with confidence because I treat most impotent men that come in after radical prostatectomy. It's something that's still widely prevalent after radical prostatectomy. I'm treating a lot of doctors post radical prostatectomy with impotence. So I'm giving you hard data here.
Wonderful, sir.
Soft data actually, but in a hard form.
That's okay. Soft data. My last question, Dr. Vineet. The two landmark trials published in June 21 and June 22. I'm referring to the Vision trial and the Procate trial. So any words on these two? The game-changing trials.
No words, sir. I think I'm going to head for dinner now.
Thank you, sir.
Dr. Vineet, firstly, Dr. Vineet and Abhishek, congratulate you from all of our friends and the group for your opening and your registration today. Sir, opening of the successful clinic, sir.
Very good.
Hospital. Sir, clinic और hospital में फर्क तो है, पर मैं चाहता हूँ it should be a mega hospital, super specialty. सर, मेरा सवाल पहला सबसे पहले ये है कि जब legally I have also been asked by some of friends to give a certificate this person is potent यार, उसकी wife उससे divorce लेना चाहती है. So it's a dilemma. Is there any test that you perform? Like if I have to give a certificate of healthy heart, I would say okay, go for stress echo. If stress echo is okay, I will say 90%, more than 90% with confidence, heart is okay. And beyond that, I can go for stress thallium, and most coronary angiography. So here, is there anything to say that okay, I can certify this person is potent, although the potency will also depend on the partner, if I am not wrong.
सर हम लोग एक्चुअली जब ये लीगल मैटर हो जाता है तो हम लोग रेफर कर देते हैं सरकारी अस्पतालों में, बट ये क्वेश्चन बहुत ज़रूरी है बिकॉज it comes time and again. I mentioned, I was asked today to give this. There is, when the current test by the way is actually a penile injection with Doppler test, which is an absolutely useless test. Why is it a useless test? It only talks about the fact that you can create an erection. It's an anatomic test. It has nothing to do with potency, it has nothing to do with the intent to have sex, and it has nothing to do with the ability to have sex. It just tells you that the man can have an erection because his vascular anatomy is normal. So, currently they are accepting that test. Sometimes, again, because there is no guideline for this, the court can be whimsical in how it wants to approach it. They may ask you for a NPT or what we call a Regiscan, nocturnal penile tumescence test, but that's it. We don't have other tests.
Sir, despite all the tests, one may be potent with one partner and impotent with the other. That is also one of
Absolutely, sir. So we call it situational erectile dysfunction, which means...
what is the remedy for a person who is a nitrate and wants to use PDE or whatever PDE5?
So we always counsel them. So depending on the PD5 inhibitor that they are using, the recommendation is regarding the period before and after. One, they are supposed to carry a card which indicates that they may have taken a sildenafil or a PD5 inhibitor in recent times. So what happens is that, so how did this become a big thing? In the US, the emergency service there was trained to do one thing. If someone complained of chest pain and gave an emergency call, the paramedics would come and the first thing that they would do was to give a sorbitol sublingual and they would kill the man. Why? Because he had had a Viagra, he got some palpitations, complained of chest pain, called the emergency medical help. They came in, saw this man, did not check for what he had and gave him a sorbitol. Death. So that's how the deaths with Viagra actually happened. That's what made them make this rule that you have to check for what has been taken, what has not been taken. Give a gap, 24 hours if you're using Avanafil, 48 hours if Sildenafil, and 72 hours if you've used Tadalafil.
What about patients with venous leak versus no venous leak? Is there any management difference?
I'm actually giving a talk on venous leak in a world conference that's happening in Delhi on 5th, 6th, 7th, but I'll just very quickly summarize it because everyone is hungry now. Venous leak is treated by penile prosthesis surgery if it is documented venous leak. There is no other form of therapy for it.
Sir, my last question I would say, Avanafil, as you said, it is very fast acting. Most of the oral given medicines, they take some time. So, can it be in sublingual form? Because it will be even faster acting. Because the fastest acting is Disprin dissolved in water.
So they've tried these films. Tadalafil was tried as a film also, and you had Sildenafil also as a film. They claim them to be faster acting, but they've not proven them. Right now, currently in literature, the quickest onset of action is with Avanafil.
Just my last question about Eligard, about the prostate. What is the status of Eligard? I used in some of patients. What is the status present?
So all androgen deprivation therapies have a known status for use in cancer prostate. So depending on, you can actually use first line, second line, third line therapy, hormone therapy, depending on what the efficacy is and whether you're looking at androgen resistance or hormone resistance or refractoriness. But it's a useful list.
Dr. Vineet, thank you. So nice question and so आपने बड़े beautifully आपने explain कर दिया. My few questions. I'm Dr. Vinod Rana. I'm a sexologist. मेरा question है sir, FSH, LH, prolactin, testosterone. There are few hormones present in every male, and these are so-called female hormones. FSH, LH, and prolactin. सर जी इनका क्या रोल है इरेक्शन में अगर FSH ज़्यादा है, LH ज़्यादा है, प्रोलैक्टिन ज़्यादा है? क्योंकि मुझे ये समझ आ रहा है जितने भी हमारे यहाँ पर दोस्त बैठे हैं इतना स्ट्रेस है इनके दिमाग में, इनके लाइफ में, और 100% इनके सबके बॉडी में जो प्रोलैक्टिन लेवल है बहुत ज़्यादा होगा. दैट्स वाई दे आर नॉट एबल टू परफॉर्म. परफॉर्मेंस क्या होता है? परफॉर्मेंस होता है कि जब आप सेक्स करते हैं 40 से 50 मिनट आप सेक्स करते हैं नॉन स्टॉप, उसको हम परफॉर्मेंस कहते हैं. और जब हम ये बात करते हैं सोशल मीडिया पे तो हमारे ऊपर लोग हंसते हैं कि भाई डॉक्टर है ना कि सच है कि आप 45 मिनट सेक्स करते हैं? डॉक्टर है ना कि सच है कि आप एक लड़की को 10 से 12 बार डिस्चार्ज करा सकते हैं? और यही रियलिटी है, क्योंकि जब तक आपके पास सेक्सुअल पावर नहीं है, आपका इरेक्टाइल डिसफंक्शन नहीं है, प्रीमेच्योर एजुकेशन नहीं है और आप सेक्स प्रॉपर नहीं करते हैं, आप लड़की को डिस्चार्ज नहीं करते हैं. क्योंकि एक लड़की को डिस्चार्ज होने में तकरीबन 5 से 8 बार डिस्चार्ज होना पड़ेगा, तब जाके वो डिस्चार्ज हो जाएगी, तब जाके वो सेटिस्फाई होगी. मेरा क्वेश्चन आपसे सर सिंपल तरीके में, मैं हिंदी में इसलिए पूछ रहा हूँ क्योंकि मैं लोगों के साथ जुड़ा हूँ, मैं जमीन से जुड़ा हुआ डॉक्टर हूँ. मेरे जितने भी जो मेरी ऑडियंस है वो सारे हिंदी स्पीकिंग है. सॉरी सर, मैं इंग्लिश में नहीं पूछ सकता आपसे, आप बहुत बड़े डॉक्टर हैं. मुझे बस खाली इतना रिक्वेस्ट है आपसे, एक आंसर कर दीजिएगा, क्या ये पॉसिबल है कि एक लड़का अगर सेक्स करता है कि उसका टाइम कितना होना चाहिए मिनिमम? और दूसरा, एक लड़की को सेटिस्फाई करने में कितनी टाइम एक लड़की को डिस्चार्ज होना पड़ेगा? तीसरा, FSH, LH, प्रोलैक्टिन जो 3 हार्मोन्स है फीमेल हार्मोन्स जो मेल्स में प्रेजेंट है वो किस लेवल पे होना चाहिए? और अगर वो ज्यादा है तो उसका क्या ट्रीटमेंट है? धन्यवाद। इट्स नॉट आउट ऑफ
सब कुछ टॉपिक पर। सो बहुत इंटरेस्टिंग क्वेश्चन, मैं जवाब देना चाहूँगा तीनों के सेपरेटली। सो बहुत इंटरेस्टिंग स्टडी हुई थी, ये स्टडी इंडियन मेन में भी थी, बट अनफॉर्चुनेटली हम अपने आप को अलग प्रूव करना चाहते हैं, बट वर्ल्ड वाइड जब ये पता किया गया कि ये ऐसे नहीं टेस्ट किया, इसको IELT इंट्रा वजाइनल इजैकुलेटरी लेटेंसी टाइम, सो यानी कि पेनिट्रेशन के बाद इजैकुलेशन को कितना समय लगता है, एंड बहुत अलग तरीके से किया था, स्टॉप वॉच यूज करते थे। सो पेनिट्रेशन होगा और फिर आप जैसे ही पेनिट्रेशन होगा स्टॉप वॉच ऑन करेंगे, और जब तक इजैकुलेशन होगा तब तक आप स्टॉप वॉच, इट्स लाइक अ रेस, आप स्टॉप वॉच बंद नहीं करेंगे। इस तरीके से इस IELT को या IEVLT को मेजर किया गया था, एंड इटालियन मेन स्कोर्ड द बेस्ट। जब ये मैं बेस्ट कह रहा हूँ तो इनने कितना स्कोर किया था? दे स्कोर्ड 15 मिनट्स, दे डिड नॉट स्कोर मोर देन 15 मिनट्स। सो वो 40-45 मिनट इनने स्कोर नहीं किया, इनने 15 मिनट स्कोर किया, एंड दैट्स द बेस्ट स्कोर दैट वाज फाउंड इन अ वर्ल्ड वाइड स्टडी ऑन इजैकुलेशन इंटरवल्स इन मेन, यानी कि इजैकुलेशन टाइम्स इन मेन। इसके अलावा शॉर्टर इंटरवल्स, एवरेज इंटरवल्स वर्ल्ड वाइड जो मिले वो 5 से 8 मिनट के बीच में मिले। अनफॉर्चुनेटली जो ISSM की डेफिनेशन है, यानी कि इंटरनेशनल सोसाइटी ऑफ सेक्सुअल मेडिसिन की जो डेफिनेशन है, वो इन सब टाइम्स को नहीं लेती है। उसने पहले टाइम को एक क्राइटेरिया रखा कि हम टाइम रखेंगे, एक क्राइटेरिया कि इतना समय होना चाहिए तब ये जरूरी है, बट उन्होंने ये देखा कि टाइम मैटर नहीं करता है, क्योंकि वहां पर सेटिस्फैक्शन ही मैटर करता है। सो उनने उस सेटिस्फैक्शन को एक स्कोर बना दिया, एंड उस सेटिस्फैक्शन के बेसिस पे इस स्कोरिंग को फॉर इजैकुलेशन टाइम, सेटिस्फैक्शन टाइम, इसको इस सेटिस्फैक्शन स्कोर से देखा। फिर भी उन्होंने एक मिनिमम टाइम क्राइटेरिया बनाया, बिकॉज दे वांटेड टू पुट अ टाइम टू हाउ मच शुड बी अर्ली इजैकुलेशन डिफाइंड एज। सो लेस देन 2 मिनट्स वाज डिफाइंड एज अर्ली इजैकुलेशन। वहां से उनने इसको खुला छोड़ दिया, यानी कि इसके बाद जो भी समय है वो कपल की सेटिस्फैक्शन के ऊपर है। बहुत सारी चीजें ना एक्सपेक्टेशन भी होती हैं। अब आप फिल्म देखते हैं और फिल्म में देखते हैं कि वो तो इजैकुलेशन हो ही नहीं रहा है, बंदा भी लगा हुआ है, बंदी भी लगी हुई है, देयर इज नो एंड टू इट। ये हकीकत नहीं है। जो हकीकत है वो स्टैटिस्टिक्स और एविडेंस पे बेस्ड है, और जो एविडेंस बेस कर रहा है वो ये देख रहा है कि इतना समय एवरेज मिल रहा है, प्रांतों में अलग अलग हो रहा है, कंट्रीज में अलग अलग हो रहा है, बहुत सारे फैक्टर्स पे डिपेंड करता है, बट एवरेज टाइम्स रीजन वाइज उन्होंने असेस किए। फिर भी उन्होंने डिफाइन टाइम से नहीं किया।
सर कोई रोल है मैं भी मैं आपके सेकंड उस पे आ रहा हूँ। अब दूसरा है हार्मोन्स का, FSH, LH, प्रोलैक्टिन, ये 3। ईस्ट्राडियोल इज अ फीमेल हार्मोन, ये 3 फीमेल हार्मोन्स नहीं है, क्योंकि FSH इज फॉलिकल स्टिमुलेटिंग हार्मोन, LH इज लुटेनाइजिंग हार्मोन, प्रोलैक्टिन वी नो, and they are all present in men and women. Follicle stimulating hormone is responsible for maintenance of spermatogenesis. LH is responsible for initiation of spermatogenesis and maintenance of testosterone. And prolactin, we know, can be elevated with the simplest of drugs. Even something as simple as a proton pump inhibitor can elevate your prolactin levels. Domperidone also. So, unfortunately, prolactin is treated wrongly for elevation most commonly. ये most commonly drugs से elevate होता है, and most commonly फिर भी treat होता है, जबकि इसको treat नहीं होना चाहिए इसके elevation को। Prolactin जब actually elevate होता है without any drug interaction, तो rarely libido disorders के लिए responsible होता है, erectile dysfunction के लिए नहीं, और FSH और LH का erection में कोई role नहीं है।
Can we have the I'm winding it up. We are winding it up. Friends, we had a wonderful discussion, and there were some questions which, in a topic like this, sir, Indra, please let me now summarize. Let me now summarize, please. There are
सारे क्वेश्चंस के reply मेरे पास है.
There are at times questions which are uncomfortable to ask in a topic as wide as this and as controversial as this. I think it's time to wind up because everyone needs to be, tomorrow is a working day and we need to really wind it up. I would like to express my heartfelt gratitude to Dr. Mishra, to Dr. Vineet Malhotra, our wonderful moderator, Dr. S K Poddar sir, and some wonderful questioning by the audience. I would like Dr. S K Poddar to summarize it in next 1 minute.
I think Dr. Vineet did justice to both his talks. He was very short and crisp in both his talks. And if we take just one lesson that in prostatic carcinoma, again I will emphasize, you don't treat without doing a per-rectal examination, and if suspected then a biopsy. So refer your patient to the, I think maybe urologist or maybe some surgeon also sometimes for PR examination. So PR examination is a must. If a GP can do it, that's fine. So proper PR examination is must before starting prostate drugs for BPH, and very nice talk on ED also. And our friends, they have started a new hospital, BNA, Vineet and Hospital. So we must support them, and that's all. Thank you very much.
Thanks very much. I think you can have your